Okay, so the next important subtopic of GUTB that we are going to discuss now is the role of imaging in genitourinary tuberculosis. So by imaging we mean what exactly the mode of diagnosis is going to be. Earlier we discussed the biochemical and the urine culture methods of diagnosis. Now we are going to discuss the radiological imaging of genitourinary tuberculosis. How exactly you can make a diagnosis of GUTB by the use of ultrasonogram, by the use of intravenous urogram, the CT scan and the MRI. So that is what we are going to discuss now. Let me just recap the history. We have a patient with who is a 35-year-old male who had complaints of loss of appetite, loss of weight and fever with the predominant storage symptoms. Having received ATT 15 years back, has urine AFB which is positive, and the working diagnosis of GUTB being made. Yeah. Now if you do an ultrasound, what do we see here? See, the findings that you see may be varied depending on the situation that we are in, depending on the degree of damage caused to the kidneys. So for example, the one here in the top left, you can see this image shows an ultrasound of the kidney where you have the liver here, and this is the right kidney. You have the individual calyces which are standing out prominent, not communicating with the centrally located renal pelvis. You can't see the pelvis here, the pelvis is not dilated, but each of the individual calyx, the upper calyx, the middle calyx and the lower calyces, they are all individually dilated. They are all not communicating with the centrally dilated renal pelvis, which is again a hallmark of tuberculosis, renal tuberculosis I mean. Why is it happening? Why does it happen like that? Sorry, I'll repeat again. So why does it happen like that? It happens because the individual calyces usually communicate through the infundibulum to the centrally located renal pelvis. In patients with renal tuberculosis, there is an infundibular narrowing, as a result of which the calyces stand out prominent, but they do not communicate with the pelvis, centrally located pelvis, because the infundibulum are narrowed. The interlobar arteries and the interlobular arteries are the ones which get endarteritis, as a result of which there is an infundibular stenosis, which results in non-communicating calyces, which is pathognomonic of renal tuberculosis. You may get another picture like this, where you have the pelviureteric junction which is narrow, and all the calyces are also dilated along with the centrally located renal pelvis. Each one of them communicate with the centrally located pelvis, and there is a global hydronephrosis because of the PUJ narrowing, pelviureteric junction narrowing. Here you cannot see the dilated ureter here. That means the stenosis is at the level of the pelviureteric junction, where there is a global hydronephrosis. This is one such presentation. The third presentation is you have an isolated renal pelvis, but each of the intrarenal pelvis, where you have the calyces are not dilated and the kidney is still, cortical thickness is very well preserved, and these patients have a centrally located dilated renal pelvis, but not much of a dilatation. So the patients can present in any form depending on the site of obstruction, site of involvement and the degree of obstruction or extent of involvement. So these are all the factors which will decide the type of image that you get in your ultrasound. So what sort of findings do you get in GUTB in ultrasound? There are early findings, you have delayed findings or end stage findings, and you have progressive findings. So what are the early findings that you see? You may have a normal kidney, absolutely normal kidney, or you may have some small focal lesions which may be there in the cortex, which are granulomas. So cortical granulomas or calcifications, they are the earliest findings that you see in renal tuberculosis. A good sonologist will be able to pick up these findings and arrive at a diagnosis. Whereas if you routinely do a good sonologist will be able to pick up these findings and make a diagnosis. The next one is the progressive findings. The progressive findings are echogenic masses with a distorted parenchyma, irregular hypoechoic masses which may connect with the centrally located pelvis, or there may not be a pelvic dilatation at all, or the echogenic foci may be there in the bladder wall near the orifice. It may progress down to the ureteric orifice and the bladder and may cause some sort of a focus which is echogenic, or a calcification in the bladder wall near the ureteric orifice. The final one is a end stage renal disease, where the kidneys become smaller, they become shrunken, and they have a thick renal parenchyma. The problem here is not the thinning out here. The renal tuberculosis will cause thickness of the parenchyma because of endarteritis obliterans of the interlobar vessels, and this will cause a shrunken kidney but a thick parenchyma, which is again a hallmark of renal tuberculosis. And the patients with an extensive bladder involvement may have a small fibrotic thick walled bladder as well. Okay, moving on. what are the limitations of ultrasound? Does ultrasound give you the diagnosis all the time? I said earlier that a good sonologist will be able to pick up a cortical granuloma, but does that happen all the time? Do we have good sonologists reporting all this all the time? There is always a possibility of a human error as well, and these procedures are observer dependent, so there is a very likely possibility that these granulomas, even if they are present, can be missed out by the sonologist during routine ultrasounds, and these ultrasounds are also less sensitive than a CT scan in detection of epicalisial or a pelvic or ureteral abnormalities. And patients with an isoechoic parenchymal mass, it may not be possible for us to distinguish these masses from the rest of the parenchyma, or if there are small calcifications, the central sinus echo may also be echogenic, and you will not be able to identify the small calcified spots with a higher degree of accuracy. Small cavities that may communicate with the collecting system are easily missed out. So these are all the limitations of an ultrasound, whereas as I mentioned earlier, a cortical granuloma is one of the earliest findings that you get in patients with renal tuberculosis. On the other hand, if you have a very high resolution ultrasound machine, the small irregular caseous cavities can all be identified. A tuberculous cavity with fine septate can all be identified, and irregular sonolucent cavities with semi-solid structures, echo textures inside them can also be identified with a higher degree of accuracy. And sometimes the kidney may be so much enlarged that may be a palpable renal mass and may mimic sometimes xanthogranulomatosis pyelonephritis. So these are all the ultrasound findings that you get in various types of renal tuberculosis that you come across.